Welcome. I'm Megan K. Corrigan. I'm with the Michigan Association of Counties. And welcome to all of our attendees here today. And a special welcome and thanks to all of our panelists today for this great partnership. We have a great partnership with the Department of Health and Human Services and the Attorney General's Office, as well as MML and FTA, particularly to talk about this national opioid settlement, the historic settlement. And so today we hope to do a brief overview and offer some resources to all of you on here today. A few housekeeping items. We are recording this session. So afterwards, if you want to share that or anything, it will be made available through our associations. We'll put that on our website, and that can be viewed by you again if it is that exciting. You want to watch it again or share that with any of your colleagues. There's a Q&A feature in the chat box that you can ask questions during the session. Feel free to put that in at any time during the presentation. We'll wait until after. I'll go ahead and moderate those and direct them to our panelists. And if a question doesn't get answered, if we run to our maximum time limit here at 4 o'clock, we'll be sure to follow up with you and make sure your question gets answered. If you think of anything afterwards, please feel free to reach out via email and we can provide an answer that way as well. So with that, welcome. I want to just turn it over quickly for an introduction from our friend at the Michigan Municipal League, Harisana.
Thank you so much, Megan, and good afternoon, everyone. I'm Harisana Richards, a legislative associate with the Michigan Municipal League. Again, welcome. It is so great to see so many attendees who've been able to join us here today. And again, an extended thank you to our partners at MTA, MAC, DHHS, the Attorney General's Office for partnering with us for this event today. We are very excited to bring everyone together to share some best practices, resources, and hopefully some good dialogue following the end of our presentations. And so with that, I will turn it over to Judy.
Thanks, Harisana, and thanks, Megan. I just, again, would echo the welcome to everyone who's participating. I think this is great. I know that it seems like for a little bit of time, we were scrambling, trying to make sure that we had contact with all of our members and got the information out that we had. I know the panelists, they've been great resources for us as we've moved forward. And so thank you to them in advance. And again, I think we are open to a lot of information, resources, and getting your questions answered, maybe not just today, but in the future. So with that, you want me to jump right into the panelists? Okay, Megan, thanks. Okay. I get the pleasure of introducing Matt Walker. Matt is an Assistant Attorney General in the Corporate Oversight Division at the Attorney General's Office. Matt is the one that I think I have worked with the most, and he's probably tired of all my emails and questions, especially in December and the week of Christmas when there was a lot of timelines to be met and we were trying to make sure we got information to members. So Matt works on the Michigan's opioid litigation and serves as the AG's designee on the governor's opioid task force. Prior to working in the Attorney General's office, Matt worked for the State Court Administrative Office, the 30th Circuit Court, and he was also in private practice. Matt received his BA and his JD from Michigan State University. So go green.
Hi, thanks, Judy, and thanks everyone else. I could never get tired of your emails and questions, Judy.
Thank you.
Well, thank you so much to MAC and MTA and MML, as well as our DHHS partners for being able to get together today. I really appreciate all of you being here as well, and I'm hopeful that I can share some information with you about the opioid settlements that we have going on right now. And like everyone else said, if you have any questions, please feel free to ask. And with that, let me kind of get into the slides here. So, as you all know, we have some opioid settlements that are happening right now. And these opioid settlements are specifically with the wholesale drug distributors and a company called Janssen. So in 2017, there were approximately maybe 2,000 federal lawsuits that have been filed by government entities against opioid-related defendants. Among those defendants were opioid distributors and manufacturers. And then in 2017, a federal judicial panel got together and decided to put those into what's known as a multi-district litigation. It's often shorted to MDL. It's consolidated under one judge in Cleveland. That's Judge Polster. And then after in 2019, a settlement was announced with Cardinal, McKesson, Amerisource, and AmerisourceBergen, which are the nation's three largest wholesale drug distributors, and as well as a company called Janssen, which is a subsidiary of Johnson & Johnson. So if you hear someone say the settlement was with Janssen or Johnson & Johnson, they usually use those terms synonymously just because it's a little bit easier and people are familiar with Johnson & Johnson. So in 2021, the terms of the settlement were released in July. And so since July, we've been working with that and trying to get everything around and get as much participation as we can. So the important thing to know first is who is settling, okay? So you may hear this often referred to as a national opioid settlement. And that's not wrong. This is a national settlement. It's with a lot of different states and a lot of different municipalities. But I want to make sure that you know that this isn't the only settlement that's going on right now. This is just one of many cases that's happening at this time in the opioid space. And we're hoping that in the future, we have more settlements that come along. But at this time, this is the one that we're working with. This is likely to be the largest one that we see. And this is the second largest nationwide settlement in history, right behind the tobacco settlement. So just so you know, that's what we refer to, and we're hopeful to have more settlements in the future. So the question is, what exactly are we settling? So I wanted to make sure that I touched on this because it's easy to talk about a settlement, but we often kind of forget to talk about, well, what's being exchanged in order for what we're getting. So in exchange for the government's releasing their claims against these different companies, these companies have agreed to do certain things and pay certain amounts of money. So doing things in legal terms is often known as injunctive relief, and then paying money is usually known as like monetary payments or monetary relief. So what do the defendants have to do? So let's first take Janssen. Janssen was an opioid manufacturer, and in exchange for the settlement, Janssen has agreed to stop manufacturing opioids, stop selling opioids, stop promoting opioids, stop lobbying for and against opioids at varying levels of government. And one of those levels is, all of those levels are the federal, state, and even regulatory. And I think it's important to point out the regulatory lobbying as well, because that's an area that often isn't thought about, but is an important area because a lot of things can happen with different regulations. The next one is with the distributors and what they have to do. The distributors is a little bit different than the Janssen injunctive relief, and that's because the distributors have a different role. They're truly drug distributors. So they've agreed to create, I would say most importantly, a national clearinghouse where data about opioid sales will come in and be shared amongst those companies. So that, let's say as an example, a pharmacy ordered 1,000 pills and then turned around and ordered another 1,000 from a different company. So as it stands right now, they wouldn't really have a way of telling each other that that happened. But with this national clearinghouse, we're really hoping that that information will be shared, and then they'll have an idea of what's going on with other companies so that they're not extending and supplying too many pills in one specific area. It's also important to know that that information and data, at least some of it, will be shared with state regulators so that they'll know what's happening, and they'll have that data to be able to pull from, analyze, and use as a resource for future programs or things that those individual governments would like to do. So now let's talk about the monetary payments. So what do the defendants have to pay? So all total, the distributors and Janssen will pay approximately $26 billion over the course of 18 years, and that's nationwide. Michigan, as a state, will receive approximately 3.4% of that. It's roughly $776 million, and that occurs over the course of 18 years. So one important note that I want to make to you is that it's unlikely that those payments will be the same from year to year. So the number will be like, you can't just take the number and divide it by 18 to get an average of what you think you'll get year to year. The payments will likely change because of different things that are happening within the settlement and different incentives that have been provided by those different companies. One thing that is key is participation of local subdivisions across the country. And in Michigan, we did very, very well in having all of those eligible local subdivisions participate. We had 269 of 278 eligible local subdivisions. That's 97% participation. So I really applaud you and thank you so much for participating. So the reason that participation is so important is, from what you can tell from the chart here, there's different incentives that happen with the settlement, and the incentives are very slightly different from the distributor settlement to the Janssen settlement. But let's just talk about the distributor settlement first. As you can see in the corner here, we have base payments of 55%. So that means that we start at a 55% base payment. And then the rest of the payments are made up by incentives. And incentive A is the one that we're trying to achieve. And then, so incentive A is 40% of the money. And then we have incentives B and C for different levels of participation. Incentive D is a 5% share of the state's total abatement fund. And that's based on no individual local subdivisions suing these companies over the course of approximately 6 years. So incentive D doesn't kick in until year 6. The Johnson & Johnson incentives are approximately the same. There's just a little bit of variance in between the two. The base payments start at 45% and the incentives make up 55%. And there's some difference in incentive B and incentive C. So as you can probably tell, participation is of great importance in these settlements because it's really the only way that we can make sure that we receive all the money that we're supposed to get. So next is implementation. The question is, well, where are we at in this process? So I'll be happy to tell you that last Friday on the 25th, both the distributors and Janssen stated that they were continuing with the settlements and things were moving forward. So we were in a holding pattern here to see if they decide if there's been enough participation to continue. But now I can tell you that there has been enough participation and we are continuing with the settlement. So that's great news. The next thing I want to talk about is the Michigan State Subdivision Agreement. So first, if you want to take a look at this, it's available at michigan.gov/AG opioids. And what's important about this Michigan State Subdivision Agreement is that this is really what controls the allocations of funds to the state and local subdivisions. So this is what we have done to replace what was in the Master Settlement Agreement. So the Master Settlement Agreement provides for a default payment breakdown or default allocation, and that is 15% to local subdivisions, 15% to the state, and then a 70% bucket that's sort of jointly administered between everyone. So the state negotiated with the litigating local subdivisions, and we agreed to a 50-50 split instead of that 15-15 split. The allocations to individual local governments are determined by a nationally used formula as modified by a litigation adjustment. And then I also wanted to note that individual subdivisions that aren't receiving like a high amount, so it's a percentage that we based it on, but it equates to approximately $7,500 overall. They would receive that money upfront in the first year. The other thing to note is that if you're a local subdivision and you're wondering, and I say this because I heard this from a number of different folks, is that if you're wondering, can I give my allocation to someone else? The answer is yes, you can. You can give it to another participating local subdivision. So you can give it to your county, you can give it to a different participating local subdivision, and I'm trying to work on a form to make that real easy for you. A little bit more about the Michigan State Subdivision Agreement. I wanted to talk about attorney fees. Attorney fees are limited to 15% of an individual litigating local government's recovery, and that 15% is offset by a national fee fund that was established within the settlements. So I give you an example here. Subdivision A contracted with an attorney for a 30% contingency fee. And attorney X's fee is limited to 15% of Subdivision A's recovery. It's limited by our state subdivision agreement and also by an order of the court. So overall, then what happens is, so we have that 15% fee. The National Fee Fund ends up paying 7%, and the remainder is paid by the litigating local government attorney fee fund. And so those fees end up being paid over the course of 7 years. And that's the same time frame that the National Fee Fund pays as well. There's also an option for a special circumstance fund. So if you believe as a local subdivision that something wasn't right with your allocation and something isn't captured by the allocation formula for you, then you can apply to the special circumstance fund to receive some additional funding. Currently, the application deadline is set for March 30th of this year, but we're actively working to push that date back just because everything seems to be taking a lot longer than anticipated. So that would be not just related to COVID, but really everything related to the settlement. So the next question is, how can you use settlement funds? And this is something I don't want to get too deep into because I know that our DHHS friends are a little bit better to speak to this than I am. But I just wanted to let you know from the settlement standpoint, how the settlement funds are to be used per the settlement. So it's really governed by the term opioid remediation, which is a defined term within the different settlements. But it's guided by Exhibit E of the distributor and Janssen settlements. So basically there's a definition in there that says you have to use the money for opioid remediation, and then it gives you a bunch of examples in Exhibit E. So some of those examples are opioid use disorder, treatment and recovery, connecting people to help, addressing the needs of criminal justice involved people, prevention, first responder support, naloxone, all of those different things are some options that you have within the settlement to use the money. So I hope that that is something helpful, and I hope that this has given you a good overview of the settlement and how it works. And if you have any questions, I'd be happy to answer them. I think that, well, I got one more slide, I'm sorry. So the last question is, when will payments begin? We're hoping that the first payment will be as early as April of this year. And then the next payment would be in July. So this year we'll have 2 payments, but then subsequent payments would be annually in July. And that's all the slides I have for today. And I really appreciate everyone being here and listening. And I'll turn it over to Harasana.
Thank you so much, Matt. I, for one, actually, this is really helpful information to me to see it all together, and just so much opportunity with this and great information that you shared with us so concisely. Thank you. All right, shifting gears towards best practices and an overview of some of DHHS statewide opioid strategies, we have joining us today, Dr. Debra Pinals.
Great.
Dr. Debra, oh, hi, hello. We have your slide up? Excellent. Excellent. All right. Well, Dr. Pinals serves as the Medical Director of Behavioral Health and Forensic Programs for the Michigan Department of Health and Human Services, and is the Director of the Program in Psychiatry, Law, and Ethics, and Clinical Professor of Psychiatry at the University of Michigan Medical School, and Clinical Adjunct Professor at the University of Michigan Law School. During her career, she has been a clinical advisor related to the opioid crisis and has consulted on complex systems cases for people with mental illness, substance use disorder, and intellectual and developmental disabilities who are receiving treatment or support in various places, such as community, court, carceral, forensic, and state hospital settings. She teaches and publishes extensively and has led and consulted on numerous federal grants, including those related to opioids, juvenile justice, and behavioral health and justice partnerships. Welcome, Dr. Pinals. Please begin.
Thank you so much, Harasana. And it's a pleasure to be here. And thank you, Matt, for providing that just really good overview to get us sort of level set on what's to come. My part of this presentation is to provide you with information about where the task force looking at the opioid crisis has landed and the strategies within the Michigan Department of Health and Human Services that we are trying to roll out to help turn the ship on the opioid crisis. So I'm going to go over state strategy and next steps. Next slide. So with this settlement, this allows us to follow 3 key principles that we have identified within the state. First of all, the goal is to align the settlement funding with state of Michigan opioid strategy. It will be very helpful because we are also getting additional federal dollars that are coming our way to help with the opioid crisis and other aspects of the substance use disorder crisis. But aligning the settlement funding with the state of Michigan opioid strategy, we think will have the best impact in terms of helping to reduce the number of opioid overdose deaths. We also want to follow the principle of addressing systemic barriers to services. We know that there are systemic barriers, and our hope is that through the settlement dollars and the opportunity for various levels of government and the recipients of those dollars to work together, that we can really focus on addressing those systemic barriers. And then lastly, we want to provide equitable distribution of funding. We absolutely are recognizing that there are disparities. I'm going to talk about this a little bit more in terms of who's been impacted by the opioid crisis. And we want the funding to be able to be done, to be distributed equitably, so populations that may be at greater risk are able to get the funding proportionate to their risk. Next slide. So this is a complicated chart, and I'm going to go through each pillar in turn, but this is essentially what we've landed on as our state of Michigan opioid strategy. And this is through the task force, which has membership from all the different state agencies and the courts. And essentially, we're trying to look at tackling the opioid epidemic with regard to prevention, treatment, recovery, harm reduction, criminal legal, pregnant and parenting, data, and equity. And you'll see that many of these things that we are talking about were already things that Matt presented in terms of the settlement dollars and what they are supposed to be allocated for. Next slide. So just taking them in turn, with regard to prevention, we have been launching for several years now targeted media campaigns to destigmatize seeking help and to alert the public towards what the needs are. And we think that has had some significant impact. We've made media campaigns that are we hope represent diversity and equity. And those are ongoing efforts that we are involved in. You may have seen some of the billboards or other ways that we've approached the media. We're also funding academic detailing and prescribing best practices programs. So what that means is that through, for example, our Medicaid services, if a prescriber is seen to be prescribing sort of outside of established boundaries, there can be somebody who would go to that prescriber and provide them some education around their prescribing practices. We have found, and there's a lot of literature that shows that providing a supportive role and an educational role to prescribers is one of the best ways to help them address their prescribing practices. We're also providing educational materials and expert consultation services for prescribers to promote best practices, especially for high-risk areas or medical specialties. We're supporting and promoting prescription drug take-back events where people can have days where they have, in the local park, safe disposition of drugs that may be lying around in people's houses that we know are really part of the problem in terms of the opioid crisis. And so having people be able to bring their medicines back to a safe location is one strategy that we find helpful in prevention. And then lastly, to mention the Michigan Automated Prescription System, the MAP system, which is our prescription drug monitoring program, to monitor controlled substance prescriptions and identify potential inappropriate prescribing practices. And now, for example, when I am prescribing by law, if I'm prescribing a controlled substance, I would be looking in the MAP system to see if my patient was getting a prescription from any other prescriber, because that would alert me to some of the challenges of that person's needs. Next slide. With regard to treatment, we're doing a lot of things on the treatment front as well. First of all, we're working on increasing treatment capacity. We know that we have had not enough prescribers who are familiar with or comfortable with or permitted to, because of regulations, prescribe some of the medications that are used to treat opioid use disorder. We call that MOUD. That for years, people had been referring to that as medication-assisted treatment or medication-assisted therapies, or MAT. More and more people are using the terminology MOUD because it really speaks to the specific medications that have been FDA approved for the treatment of opioid use disorder. And we have something called the Michigan Opioid Collaborative, which allows for specialists to provide technical assistance and support to buprenorphine prescribers who are starting their practices or maybe struggling with some complex patients. And that's ongoing work. We're also pushing emergency department access to MOUD. We know that people present to emergency rooms after near fatal opioid overdoses. And it's really important that when they are seen in the emergency department, that there is an ability to get them what we call inducted on medications so that they have a much greater chance of survival when they leave the emergency department without a return to opioid to their opioid use disorder. And through that, we're partnering with the Michigan Opioid Partnership to expand MOUD in emergency departments across the state. So in those ways, we're really trying to increase treatment capacity. We're also trying to reduce the administrative barriers to get people into treatment. For example, in late 2019, we were one of the early adopters of removing Medicaid prior authorization requirements for buprenorphine, which required prescribers who wanted to use the proper medication for opioid use disorder to go through some additional hoops before they could get the authority to do so through Medicaid. And we've removed that requirement, which just eases access. We've also updated the Medicaid reimbursement policy for opioid-based opioid treatment in 2021, which allows providers to bill for certain services that they hadn't been able to bill for before if they are treating somebody with opioid use disorder. We've also received federal approval to change the Essential Health Benefits Plan to expand access to treatment and naloxone in public and private health insurance, which is another great strategy as we move towards getting naloxone in the hands of as many people as possible to help reduce the chance of fatal overdose. Next slide. In terms of recovery supports, this is an area of great interest for us. The opioid use disorder and substance use disorder treatment costs, case management, and transportation issues that we've been looking at, including covering costs for individuals who need access to treatment. They might need transportation to get to treatment, and they might need case management to help support their recovery. And so we're working on developing strategies to help fund those. We've built in opportunities for peers, people with lived experience with opioid use disorder, to work in emergency departments. Sometimes that peer-to-peer interaction is what helps an individual move towards their path of recovery in a more positive direction. And so by strategically placing peers in emergency departments, outpatient clinics, and community settings, we hope to engage people in their own recovery. We're looking at recovery housing as well in terms of covering recovery housing costs for individuals with these disorders. And we're looking at certification of recovery residences, which would certify recovery residences in Michigan according to standards through the National Association of Recovery residences. And that is something that we're continuing to work on to, again, improve the chances of an individual being able to go into a proper recovery residence to move them, help them, support them, move towards their path of recovery. Next slide. In terms of harm reduction is a strategy that essentially entails understanding that this is that opioid use disorder is a chronic illness, just like diabetes and high blood pressure. And what we try and do in medicine is really try and mitigate or minimize the harm overall of the chronic illness, recognizing that we may not immediately cure the chronic illness, and we may not fully cure it because people might need to be in recovery or are going to be in recovery for long periods of time. But by producing harm reduction strategies, again, we can shift people towards recovery. So, for example, promoting naloxone distribution in key locations and expanding the scope of the standing order, including building a naloxone portal that allows for bulk orders of naloxone throughout Michigan, is a harm reduction strategy. Because although it doesn't treat the disease of opioid use disorder, it helps reduce the chance of a fatal overdose by allowing that rescue medication to be given and having that person potentially being able to access care and treatment. We're also promoting the adoption of EMS leave-behind programs and requiring licensed EMS vehicles to be equipped with naloxone. Again, another harm reduction strategy. We're expanding syringe service programs and increasing service delivery in communities of need, with 81 locations operating now in Michigan. We're conducting street outreach also in high-need communities. And all of that helps reduce the chance of infectious diseases that are carried through dirty needles, as well as promoting recovery principles and helping people who may continue to be using, but helping them do so in a way that reduces harm and, again, hopefully moves them into a stage of readiness for treatment. Next slide. With regard to our criminal legal strategy, this is an area of great interest. We know by lots and lots of research that people with medication, with opioid use disorders are frequently found in carceral settings. They go to court for criminal charges, maybe other types of related things, child welfare, removals, things like that. And so from a criminal legal perspective, we're trying to work with the jails around getting access to medications for opioid use disorder and inform funding strategies for that. That's an area of great need. It's a challenging area for lots of reasons in terms of institutional security that people have been worried about historically, but more and more jails are coming on board with providing medications for opioid use disorder for individuals in their custody. And we are also working with the Michigan Department of Corrections, providing technical assistance on their medication for opioid use disorder pilots. They're also doing a lot of work themselves with regard to enhancing and expanding access to MOUD within the prison system. And through that work, we're also working with them around people coming out of the prison system so that they're connected to care as well. Where the courts are expanding the number of treatment courts that address people with opioid use disorders. We're supporting MOUD use in treatment courts through technical assistance, education, and funding opportunities as well. We're also working hard to support training for judges, prosecutors, and defense counsel on the science of addiction. Again, the medications used for opioid use disorder, because there's been so much confusion about it over the course of history. And then also the requirements for through the Americans with Disabilities Act, which would require accommodations and addressing care in the least restrictive settings. Next slide. We're also in the criminal legal front working to streamline Medicaid reactivation so that people who are moving from jails back into the community have their Medicaid turned on so that they can have access to care more immediately. We're establishing data sharing procedures between Medicaid, the Michigan Department of Corrections, as well as county jails. And we're piloting law enforcement assisted diversion programs and secure diversion spaces to help people who on the ground are met with by police on low-level offenses who can be redirected towards treatment instead of incarceration. And then finally, we're expanding the Angels program to help people who are willing to basically approach treatment and let public officials know that they need to get access to care without the risk of being arrested. So they can go to the police and say that they want to bring in their paraphernalia and really get into recovery. And so that's something called the Angels program that we've been working on expanding to allow for additional opportunities for diversion away from arrest and into treatment. Next slide. We have conducted now 2 years in a row a survey of the Michigan jails to help enlighten us on where we can identify barriers and help improve practices. And we've given this feedback back to the Michigan jails. We're one of the few states that has, and maybe the only state that has collected data from pretty much every jail within the state, looking at how MOUD treatment is accessible or not, and where, again, we need to make interventions or help provide technical assistance for the jails that haven't yet been able to expand their MOUD treatment. Next slide. In our next pillar that I wanted to discuss, we are working on pregnant and parenting women's initiatives, and that includes rooming in plans for infants with what's called neonatal abstinence syndrome, which is when a baby is born to a mother who's got an opioid use disorder, and the baby may themselves be at risk. And so therefore, the strategies that are really seen as more evidence-based include ways to help the babies and the mom stay together and really build in plans of safe care for the family. We're also working on High Touch, High Tech project to use a tablet administered app to screen pregnant women for mental health and substance use disorders and then connect them to treatment. We were also awarded a state pilot grant program for the treatment of postpartum women. This is a grant that provides up to $900,000 a year for 3 years to our prepaid inpatient health plans, regions 2 and 7, to support parenting and pregnant women, with a primary substance use disorder diagnosis, as well as additional funding for the high touch, high tech project. And this should give you all some ideas as we talk about what the state is working on, as we look at aligning the strategies with the opioid settlement dollars. Some of these initiatives may be things to tap into to expand their reach. Next slide. Also, it's very important that we address disparities. As I mentioned previously, we saw in 2020 that the overdose data showed alarming racial disparities. For example, the opioid overdose death rate for Black residents increased from about 29 deaths per 100,000 in 2019 to almost 38 deaths per 100,000 in 2020. The overdose rate for Hispanic residents increased from 15 to 22 deaths per 100,000. And these were not increases that were seen in other populations. So there's clearly disparities in who's becoming impacted from the opioid overdose crisis. The Michigan Opioid Task Force therefore set to launch a racial equity group to address these disparities, which would support culturally competent community outreach in majority minority communities, promote MOUD in those same communities, and conduct an analysis to identify key drivers of disparities to then be able to tackle them as we move towards equitable solutions. Next slide. As the opioid settlement dollars were on the horizon, we worked with our partners and collected information by conducting a survey between 2021 and 2022 to ask people that had an interest in this area and stakeholders what they would prioritize if they were given these dollars. And what we saw through initial findings was that recovery support services were the highest ranking priority, followed by prevention programming, and then expanding access to MOUD. There were obviously other priorities that were also identified that we have been trying to tackle, but it was very interesting preliminary data to see how people thought that these priorities should be balanced out. Next slide. Furthermore, in these different buckets, we saw in treatment and recovery support services that residential inpatient treatment programming was a priority. In prevention activities, we saw that evidence-based prevention programs in K through 12, as well as training for first responders on programming to connect at-risk individuals with services and supports, and providing education for medical providers, all were ranking fairly high in the priority rankings. In terms of harm reduction activities, expanding program to divert and deflect individuals from the criminal legal system really ranked the highest. And in terms of population and communities, we saw addressing individuals with co-occurring mental health diagnoses and other substance use disorders was ranked as a high priority amongst the options. Next slide. We have a lot of next steps ahead, webinars starting in April to inform best practices on services for opioid use disorder, again, along the lines of prevention, treatment, recovery, and harm reduction, as well as continuing to build on future partnerships with MAC, with the Attorney General's office, with our various stakeholders, and continue to have the dialogue with all of you as more information rolls out and that we can share with our community and people across the state of Michigan. And with that, I will stop and thank you very much for your attention.
Thank you so much, Dr. Pinals. Always informational, always a great resource for us and our counties. So thanks for being here today. I am going to turn to some questions. If you haven't already entered your question into the chat field or the Q&A box, go ahead and do so now. But let's start, Matt, with a couple questions we had come in after your presentation. really looks like there's some interest in knowing exactly how much and when some of our local units of government will, or when they may be getting their allocations. I know you mentioned starting in April, but for the following years to come. And then is there a place that there's a breakdown, or that these localities can see how much is going to be coming in each of these allocations so they can do their own planning?
At this point, there is not a resource that would provide that, and part of that is because there's still a lot of different things that are up in the air at the moment. Some payments are front loaded, and some come in the back end, and so it gets a little tough to figure out what exact payments for different things. And in addition, there are some other options in the settlement agreement that allows the defendant to prepay a year in a different year. So unfortunately, I don't have a really good resource at the moment to provide that kind of information. I also want to mention that sometimes questions related to the opioid settlement are I don't want you to think I'm being cagey. I'm not trying to be. It's just that there's a lot of unanswered questions and a lot of information that just isn't very clear. And so, it makes the answer kind of well, maybe, or I don't know, or, those kinds of things. So, at the moment, in regards to what individualized payments will be, I don't have a very good answer for that. However, in the future, we may have a better resource. And if we do, I will certainly provide that to MAC, MML, and MTA.
So similar lines, we have some questions about, and one of your slides had that $7,500 payment example in there, right? So we're talking about some of these smaller localities that maybe are getting a smaller amount and kind of receiving that, I think, up front, essentially, not necessarily split up over that long period of time. So can you just reiterate that and make sure that everyone's clear kind of on that slide that talked about some of those smaller dollar amounts in that $7,500 example?
Yeah, sure. So what I was trying to relay was that for local subdivisions that are seeing just aren't seeing a large payment from the settlement, or don't have a large allocation, if your allocation amount is 0.0023% or lower, your full amount that you would be entitled to under the settlement will be paid in the first year. So this year. So let's just say, for example, over the course of that 18-year period, you would get $5,000, right? So instead of trying to give that to you over that 18-year period, which doesn't end up being very much money a year, we would pay that to you all up front, so that you would be able to use it for something all in one lump, rather than try to figure out what to do with it over that long time period. Does that make sense?
Yeah, I think so. And some questions coming in about timelines once that payment is received. So, let's say that $5,000 comes to the local unit of government, this first tranche. Do they need to spend those funds during a certain time? And is it any different for those local units of government that see that payment over that longer period of time? Is there really a deadline or an expiration to use these funds?
I'm not aware of any deadline or expiration.
Concise. All right. Question coming in about kind of teaming up and joining in with other local units. Is there a time frame that they need to make that determination? Is it before receiving a payment? You had mentioned, I wrote down a note that you maybe are working on some type of form to make that easier to partner between different political subdivisions. So can you talk about any of those timeframes that they need to be thinking about for planning and working at that local level and having those conversations?
Yeah, sure. So what the settlement says is that if you want to voluntarily redistribute your allocation to another participating subdivision, you can do that. And you can do all of it or a percentage of it. And that if you want to do that, you need to let the National Fund Administrator know 60 days before the payment is scheduled. So, but at the moment, that's not an easy thing to do for a couple of different reasons. First of all, they haven't chosen a National Settlement Administrator yet. So there is no one to notify at the moment. Second of all, if we did get a payment in April, which is like the first that we would possibly receive it, that would be well under the 60-day mark. So we wouldn't be able to meet that at the moment. So those are small like kinks in what's going on in this first year. So what I'm trying to do is to put together a form that can be used by local subdivisions to just say, I am this subdivision. I want to give X percent, 0 to 100% to this other participating local subdivision. And then at the very least, we have that in place so that those subdivisions who want to do that can try to make that work. But like I said, at the moment, there isn't a lot of detail as to where that would go and how it entirely works at this first payment juncture.
Thanks. Switching a little bit, I think this might be from Matt and Dr. Pinals, talking about seeing some questions about eligible activities. So the first being, is there a website or an area where it specifically lists out some of those eligible activities that can be funded with the settlement dollars? And then also along the same lines for either one of you, any examples of settlement dollars being used for first responder support? I think that's in quotes, so it must have been on a slide. So I'll let Matt kick that off, and if Dr. Pinals, you have anything to add to that,
Yeah. So the first place that you would want to look at the moment is at the master settlement agreement for either the distributor settlement or the Janssen settlement. You can find those both on our AG Opioids website. That's michigan.gov/AG Opioids. And then if you scroll down a little bit, you'll see them in the middle of the page. There's the two settlements. In those settlements, you'll find exhibits down at the bottom of the settlement, at the bottom of the PDF. Exhibit E is the one that you're looking for. And that's the one that sort of provides examples and guidance as to how, some of the settlement dollars could be spent. Now, keep in mind that these are examples and guidance, and they're not, it's not, something that you have to adhere to exactly. You could modify some of that to fit maybe what you want to do. But that's a good place where you might ask DHHS to partner with you or to ask for help or help decide what that might be. So, Dr. Pinals, do you have more information?
Yeah, exactly. I mean, I think it's just like the law enforcement support. I mean, that can be or first responder support that could be interpreted as getting them naloxone so that they can distribute naloxone. It could be interpreted as developing law enforcement assisted diversion programs. I think if the goal is to, again, address the opioid crisis, I think you're probably in good stead. And then in terms of partnering, we have lots of information on the MDHHS opioids website. We have a report of the task force that was produced, and I think a second one is due soon, or I've lost track of the timing, but I think the second one is due soon. And so, we'll see, there will be opportunities through those collaborations. There's also a lot of community collaborations that are building out through the courts, through the PIHPs and other networks that I think really will continue to be strengthened through these dollars.
Yeah, absolutely. I think a lot of room for collaboration and various partnerships. And actually, a question, and we're running about 7 more minutes, about some of those partnerships is, can subdivisions work with local coalitions and other organizations to serve as a fiduciary of the funds, or can those subdivisions contract the funds out to organizations who may be engaged with opioid prevention, treatment, and response efforts already?
I'm not aware of anything that would prevent that. It might be, there might be some, there may be specific questions depending on the program that you want to do, but I'm not aware of anything that would prevent you from contracting with someone or something like that.
Awesome. This is a little bit more specific, and maybe something, Dr. Pinals, you want to take a stab at it. Regarding the use of the funds again, and really specific to medical examiner offices. Of course, we see those offices in the county level continue to be overwhelmed. It says New York State Association medical examiners have addressed some of their offices' needs by using the settlement funds for their personnel and specialized testing methods. Curious if you have any thoughts on that, or any different things you've heard of through DHHS in your work with the opioid strategy, as far as use or partnerships maybe to support our medical examiner offices.
Yeah, we've been working on looking at the medical examiner needs for some time, and there have been some strategies that we've been talking about. So that is a possibility for how these funds could be used. And again, trying to align with what we're doing. We know that they've been inundated with, demand. Testing for certain substances isn't done uniformly across the state of Michigan. So there is a lot of areas of potential improvement that could then give us more data or to know what it is we need to tackle in terms of co-occurring substance use disorders and other issues.
Thank you. One that just came in is related to the funding. Can it be used to reimburse the community for prior expenses that were incurred by the opioid epidemic, or just future cost?
It's really more intended for future costs and remediation of the issue now. There is a very small amount of room for reimbursement of prior expenditures, but the vast majority of the money, at a minimum 70%, and nationwide a benchmark of 85%, has to be used towards opioid remediation. So that's really future opioid remediation.
Thank you. How about we do one last question, and then please, I've tried to get through most of them here. If I miss it, please follow up with anyone from your organization, whether it's MAC, MTL, or MML. But last question here: can the funds can the funds be used to offset matching grants that are sought to fight opioid-related matters, such as hiring grants for public safety personnel that are charged with such activities? So, is there any strings or any prohibitions on using some of these dollars to maybe, match, help match additional dollars that are available through various state or federal grants?
I don't think that would be a problem, but I'm not entirely sure. So maybe we could follow up offline about that one. I would want to look into that a little bit more.
Yes, definitely. I have it jotted down here. So we will follow up on that and get some more information out. Just again, trying to be conscious of the time here and making sure our panelists are off before 4 o'clock. Thank you all so much for being here. And I know, as Dr. Pinals had mentioned, DHHS is going to have additional information, resources available, additional series that really dig into prevention efforts, harm reduction efforts, very specific information from their experts over at the department to be a resource. So please keep an eye out from our various associations for more information about those series coming up. I believe you said starting in April. And please use us as a resource if you have any questions on the opioid settlement, any of the eligible uses, or if you just want to try to get in contact with Matt or Dr. Pinals, please reach out to us and we'll make sure to get any questions answered. So I appreciate everyone's attendance today and thank you guys for all of your partnership on that.
Thank you, everyone, for being here.
Yes, thank you, everyone.
Thank you so much.
Thanks to our partners.
Thank you.